Um, for all of you that know me, I'm Andrew Hershey. I'm the Endowed Chair and Director of Neurology at Cincinnati Children's Hospital and a professor of pediatrics and neurology at the University of Cincinnati College of Medicine. For purposes of this presentation, I'm also the chair of the Child and Adolescent Section Committee of the International Headache Society. So first and foremost, I want to thank the International Headache Society for helping to sponsor and organize this webinar. Our goal of a webinar is really to start with some of the basics, but really introduce management, diagnosis, and headache to both the experts as well as people that are novice to the field so that we really can expand and improve the outcomes of children, adolescents, and young adults with headaches. What I'm going to talk about first in the next 10 minutes or so is the sort of the diagnosis and classification, the basics of where we're starting. This is just my disclosures. None of this is relevant to this presentation. This presentation is more focused just on some of the diagnosis. So I'm going to discuss initially the diagnosis, and others will expand on that with the epidemiology. And as the seminar series moves forward, we'll move into evaluation and new treatments. So first and foremost, I want to talk about some nomenclature. I think this is important so we get all on the same page. And some of the issues that I always want to discuss is that first, that migraine really is the disease. It's not the event. It's not the individual headache. And therefore, we really shouldn't refer to things as migraines. Oftentimes, the lay public is doing it this way because they do think of the event and they don't realize and have that understanding that it's a disease that they've most likely inherited, although sometimes it can be secondarily caused. The headaches then are the episodic features that we most commonly associate with it. I say most commonly because there are other episodic features that have been identified in the long past that are associated with it. So it's part of that nervous system involvement. Additionally, the disease spans the ages. So there's really not such a thing as childhood migraine, but it's migraine in children or migraine in adolescents. So they just happen to be the population we're looking. And then finally, which the pharma industry has influenced our discussion, but really chronic migraine is a subcategory, not really the overall arching disease. Before we launch into it, I think why it's important to understand in the diagnostic pattern what's going on in children. So if we look at it that this is a disease that most likely is inherited, that means the children are going to be born with it. So the genes are there, but as they proceed through their developmental stages, they may not be able to express it early on. So you may see, especially in the early months to years, without that higher cognitive function of the prefrontal cortex being developed, that we have to interpret some of the features. And that may be why some of the earliest onsets of the episodic disorders that occur with migraine may not be recognized as part of the disease until they proceed later. Conversely, though, why do we need to recognize it early? Well, that's because the brain itself is very plastic in this early stages. So we have a great ability to both make it work well or make it work bad. So the earlier recognition means the earlier we can hopefully get to that solving. So recognizing and diagnosing the disease is really important as early as possible to have that intervening. That being said, for those of us that are getting too many gray hairs, it's not that we can't become plastic as we get older. It just takes a lot more energy to do it. So the earlier we can do it, hopefully the easier we can really change the outcomes, change the trajectory that a child's life will go through. So starting about diagnosis, so it's not something really that's new. I put a very brief and incomplete, trying to get it all in one slide, sort of history of the discussion of migraine. So there is evidence going back to 7000 BC that trepanation, or cutting a hole in your head to relieve the attacks, was evident. There's ancient writing in Sumeria that goes back over 5,000 years that talks about the sick-eyed or sick headache. Hippocrates discussed what was probably the first aura discussion, which was a shining light followed by a headache. In the 2nd century, between Arterius of Cappadocia and Galen, really disguised that one-sided headache and started adding some of the features that we classically recognize, including nausea, vomiting, photophobia, and in that case, osmophobia, which is not part of the criteria. Where does the word migraine come from? Well, it can be coined Galen in 200 AD, who used the Greek word for hemicrania and popularized it. So Galen being one of the founding physicians, if you will, for modern medicine, and called it migraine, which is close to what we call migraine. For children, one of the earliest studies I could find was from 1921 when Combe in France. And I don't speak French, so I'm not going to try to massacre this, but as a French title, discussed really headaches in children. I mentioned Valquist and Haskell because they really started as some defining criteria that to be used so that we could start to get on the same page. Part of the reason also for Valquist is he started looking at children and adolescents. So there was 1,236 children. They classified between the ages of 10 and 12. Using these criteria that they started, identified that about 4.5% of children in this age range could have migraine by their definition. And then in 1962, Belli started his study, not all 9,000 kids were followed by 40 years, but he was able to follow them over a 40-year period to show that there was about 30% of people that persisted having headaches due to migraine, even 40 years later, although they were controlled. I always like to mention Dr. Prinsky because he was one of my mentors. But in 1975, he described the concept of migraine variance, which is really the idea that early on in life, some of the things we see, whether it's episodic vomiting, colic, abdominal migraine, could be seen as one of the first presentations. And then finally, for the history side, brings us to 1988 and really our most modern era when ICHD was first presented. The concept of ICHD was really to be able to be all on the same page. So from a historical perspective, in 1988, when Jess Olson led the group, it was a group of committees that said, what can we agree upon? And so came up with criteria. As those of us that are aware in the field, it went through the second and finally the third edition. And I was honored to be on the committee for the third edition. And for the classification of migraine, we really subcategorized it. One thing within the last year, Jess Olson published an editorial that he called his big mistake. And fortunately, people said, no, it wasn't a mistake. You were just honoring the field. But really that we didn't ever define migraine. We defined migraine without aura, migraine with aura, and all the subclassifications here. But the overall umbrella of migraine missed its classification. So by default, most of us consider migraine to be migraine without aura. And then as we start to add additional features, we have migraine with aura. So one of the basics is really just starting with migraine without aura. But you can also see on here, we do see many of the other features, whether it's complications or whether the subcategory of chronic migraine. The nuance here is there is no subcategory of episodic migraine because all migraine by definition, the headaches are episodic. It's just the frequency. But there's also other episodic syndromes. So again, you don't have to have headache to have migraine if you have some of these episodic syndromes. So what are the criteria? To briefly discuss them. Again, you're diagnosing the patient, not the event. So you need at least 5 attacks. It's 5 attacks we consider over a year, although that's not absolutely defined in ICHD. We try to step through in the criteria that everything decides for every headache disorder, the frequency. So in terms of this, it's at least 5 attacks or the number of episodes. So it's ideally, some of them you can have a one-time event. If you hit your head and you have a headache immediately afterwards, you only need one event. That's an acute post-traumatic headache. There's the duration of the headache, which for the typical headache due to migraine, it's 4 to 72 hours. Children, we were allowed a shorter duration, although that probably only reflects the average headache and maybe not the worst headaches. And we removed the 1-hour components. Next in the hierarchy of the criteria is the characterizations. So what is the headache characterized as? And we can see here for the headache due to migraine, it's that unilateral location. Again, going back to the 200 AD when it was called a half-sided headache. In kids, that's not necessarily the case. The pulsating quality, the severity or intensity being not just severe, but also moderate, and then the effect on physical activity. The next section then talks about the associated symptoms. So again, for every headache disorder in ICHD, you can have associated symptoms. Some may have none at all, or allowed only one. In the case of migraine, it's nausea and or vomiting or light and sound sensitivity. As I mentioned in history, osmophobia was one of the early features that was classified thousands of years ago. It's not included in the criteria, but it is something that may be very specific for sensitivity, but not part of the criteria component. There are specific notes for kids. As I mentioned, children and adolescents up to age 18. So one of the things we did define in ICHD 3 is when does that time period occur? So to align with everything else that's done, whether it's FDA or EMU approval. 18 is sort of the cutoff. So if you're under 18, you're allowed a slightly shorter headache. We did not change the criteria for any of these other features, but used it in commentary. And that was an effort that was being made to make it unifiable across the ages, to not have callouts for specific ages. So with the exception of the shorter duration in ICD-3, there are no callouts specifically for children and adolescents, but commentary to say that you may need to use special features such as recognizing that children are bilateral, that photophobia and phonophobia may be inferred, and finally that we can add additional comments. So I just want to show what do we see. So we followed about 25,000 kids at Cincinnati Children's Hospital, looking at the ages up until age 18, showing what they present to us too. So we do have kids as young as 4 that are coming in with at least 2 to 3 headaches a week. But we do see by the time they present to us, as they get to adolescence, many of them have exceeded over half the month with headaches. So it's really starting to impact them more. If we look at the individual features and characteristics, if we look at activity climbs in terms of its impairment. Now, whether it truly climbs or this is just a representation of the child being able to tell that it climbs, one thing you'll notice is both activity changing and activity worsening are exactly aligned up on each other. So either question works. If we look at associated features, we can see each of the classic associated features like nausea, vomiting, light and sound sensitivity are represented. One thing we do see is the climbing nature of lightheadedness while the disappearing of vomiting. So there is a dynamic change that's occurring. Lightheadedness is not part of the criteria, but maybe part of the underlying pathophysiology. And then if we look at the location, we do see the clear bifrontal temporal location. So frontal first, range into bitemporal, and then still a subcategory with unitemporal. I represent the right side. There was an equal number on the left side, but the overall unilateral nature starts to really represent itself, but remains below 50% by the time kids are getting into that young adulthood. And then finally, one of the things I always like to show is the duration. And so if you only ask the duration of the average headache, which is shown in blue, you may have kids that fall below that 2-hour line. But if you ask them, what's your average headache, your longest headache, and your shortest headache, the longest headaches frequently get into that time duration. And again, since we're diagnosing the patient, not the event, then having just 5 headaches of long duration is enough to make the diagnosis. So I didn't put a conclusion slide. I don't think. Oh, I did put a conclusion slide. So standard criteria can be used to diagnose children. So we will use the standard criteria throughout this webinar series. So if you have questions about utilization of ICHD, we include that in the question and answer period. 4 questions and answers, that's at the bottom of your slide. Please use the question and answer, not the chat, and we'll try to get to those in the last half hour. There may be adjustments made for age group component. That criteria is a disease across the ages, but some of the classical presentations we see in adults may relate to brain maturation and occur through adolescence. And then finally, I've said it multiple times, we're diagnosing the patient, not the event. So not all the headaches are required to have all the features, but the patient needs to have at least enough headaches to classify. So hopefully I've given you a brief interview into the diagnosis. I'm going to turn it over to other members of our child and adolescent section to discuss topics that we'll continue to build upon. For those of you that have joined us a little bit late, I did want to mention this is sponsored again by the International Headache Society, and that we hope to present this series on a regular basis and to build on this information. It is being recorded so that if you need to come back to it, or if you missed part of it, you'll be able to see it later. So next, I'd like to introduce Serena Orr. She's going to talk about the epidemiology of headaches and will introduce herself as far as her features and characteristics. So Serena.
Hello, everyone. My name's Serena Orr. I'm a child neurologist and headache specialist based out of Calgary in Alberta, Canada. I have a clinician scientist profile, really interested in studying all aspects of migraine in youth, particularly acute treatment and the intersection between migraine and mental health. So I'm going to talk to you a little bit about the epidemiology of headache disorders in youth. And I have a few disclosures, but none of them are relevant to what I'm discussing today. The objectives are to outline prevalence and burden of disease of headache disorders in youth, and then really deeper dive into the epidemiology in this age group from a variety of lenses. So first of all, sometimes when I, talk to people that are not in our field, they'll say, "Oh, you're a pediatric headache specialist. You must not have a lot of patients." But actually, we know that about 60% of youth will experience headache disorders at some point before they transition to adulthood. And if you look at the proportion of youth that experience frequent recurrent headaches at some point prior to adulthood, so we define that as greater than 1 day per week of headache, the estimates are anywhere from 8 to 30%. So this is a big problem. I probably don't need to tell this audience about that. When we look at who presents to medical care and the prevalence of headache disorders in neurology outpatient practice, consistently headache disorders are within the top 3 reasons for consulting a pediatric neurologist. And then if we look at, the most common diagnoses in this setting, really migraine is the most common diagnosis made in this setting, with anywhere from half to 88% of the cases seeing a pediatric neurologist ultimately being diagnosed with migraine. So tension type headache, if you look at population-based studies, is likely the most common primary headache disorder. And the estimates actually, we seem to have better epidemiological estimates of migraine, probably because as the people that study this, we find this more interesting because this is what comes to practice. So the estimates aren't as precise for tension type headache, but it's probably at least 1 in 5 youth who will experience tension type headache, so quite common. And then if we look at the estimates of migraine, there have been a couple of really nice systematic reviews that have pooled all of the worldwide studies together to try to estimate the worldwide prevalence of migraine in youth, and it's probably around 1 in 10. The latest systematic review that was published mid last year by Onofre and group estimated across all age groups of children and adolescents that it was 11% worldwide who had migraine. We had a similar estimate in a Canadian study as well. So let's talk a little bit more about the epidemiology of migraine. This is a figure from the WHO Global Burden of Disease study. They did a neurological sub-study where they tried to look at all neurological diseases and quantify disability associated with those diseases using disability adjusted life years. So the number of years that somebody lives with disability due to their disease. So if you look at this figure, and you look at this section from age 10 to 60, you'll notice that the olive component of the bars is the largest proportion. And this is the amount of disability adjusted life years for migraine, showing that migraine really is the most prevalent neurological cause of disability from 10 to 60 years of age. And if you look at the global WHO Global Burden of Disease study, so including not just neurological diseases, but all diseases, migraine has been estimated, in the version that had the highest bar for migraine, because it does fluctuate a little bit, but migraine can be up to the second most prevalent and most disabling disease worldwide when you pool all diseases together. We did a study a few years ago where we tried to understand the impact of migraine on youth when you look at health-related quality of life. So we used a measure called the PEDS-QL, which is very commonly used in the pediatric literature, and it looks at overall health-related quality of life and then psychosocial health and physical health as subscales. What we found is that in our sample of 85 youth, those with migraine had lower health-related quality of life compared to a healthy sample, which wasn't very surprising. But then we also compared them to data from a chronically ill sample. So these were youth who endorsed a chronic disease who are being seen in rheumatology, orthopedics, or diabetes clinics. And the youth with migraine had lower health-related quality of life compared to that sample as well. So just another way of looking at the impact of disease. And it's really pretty logical, I think, when you look at the impact of a child or an adolescent, the impact of having any type of chronic pain and these recurrent headaches, it's really quite a multidimensional burden. So all of this has been backed with data at some level in youth with migraine. But if you look at the impact of the child's education, we know that youth with migraine have decreased performance in school and increased absenteeism. And there's even 1 or 2 studies have shown reduced rates of high school completion in this population. There was a study done years ago to look at the impact of migraine on friendships in youth, and that showed that youth with migraine have reduced number of friendships compared to their peers. We also know that there's a lot of stuff going on in these families. So there's a higher burden of adverse childhood experiences in youth with migraine. And some of our work has shown that having adverse childhood experiences in the first 7 years of life is longitudinally associated with a higher risk of developing migraine as an adolescent in a dose-response relationship, which suggests there may be a causal relationship there. We also know from some of our other work that having a family with high levels of dysfunction early in life may be associated with a higher risk of migraine. And then you can imagine, because of all the impacts on the affected child, how that may impact their sibling and their parent relationships. And then obviously having any type of chronic pain, including these recurrent headaches, can have a lot of impacts on the child's development and on their occupational planning. So when does migraine present? This is a nice figure that we adapted for one of the publications that I did with Dr. Hershey when we were working together on the incidence of migraine per sex and per age. And this is adapted from Richard Lipton's work. And so what you can see here is that prior to puberty, the male to female ratio of migraine is approximately 1:1. And once we hit puberty, that diverges. And we'll talk a little bit about that in a few more minutes. But what I really want to draw your attention to here is that if you look at the incident cases, the fastest rise in migraine incident cases is really in adolescence after puberty hits. So this is a huge opportunity for us to get early diagnosis and treatment. And it does matter. What we do really matters. There isn't a ton of data on this. I hope to see more in the coming years, but there's at least a couple of studies that have shown that if we get in early with a diagnosis and treat appropriately, that we can impact the long-term prognosis of these patients. And we know that migraine is associated with lifelong, not only physical health problems related to the disease, but also increased incidence of mental health problems. So there was one study that looked at a 6-year follow-up, and they found that those who came to care earlier and had a diagnosis earlier had increased rates of headache freedom at 12 months compared to those who had a longer lag between when the headache started and when they presented to care. And there was another small study that looked at a 10-year follow-up window and again found that that shorter lag to onset of disease and care was associated with reduced likelihood of having ongoing migraine symptoms at 10 years. What about age? Now, I think actually Dr. Hershey touched on this with their Cincinnati data. So some of this will be repetition, but sometimes that's good for learning. So younger children tend to have more of a bifrontal or bitemporal presentation, so bilateral symptoms in terms of where the pain location is, and a higher prevalence of nausea and vomiting. This has been corroborated now also in Dr. Hershey's data that he showed, but in several published studies. And the older children tend to have a few differences as well compared to the younger children. So we see a higher prevalence of aura at an older age. We see a higher prevalence of reporting a throbbing nature to the pain and unilateral pain. Also, a couple of studies have shown a higher rate of photophobia, so sensitivity to light in the older adolescents. And as we saw very beautifully with the Cincinnati data, an increasing rise in headache frequency over time in the older kids. And so we touched on this a little bit in another slide, but we do see a big divergence in the sex ratio depending on where we are in relation to puberty, so that we see that prior to puberty, the male to female ratio is 1:1. And then once you hit puberty, you see that big divergence in incident cases. We also see sex differences in terms of the prognosis. So there's not a lot that we understand in terms of who will go on to have symptoms of the disease long term, like out into adulthood. But one of the consistent features that comes out is that males are more likely to go into remission at some point in adulthood or to have lower severity of the attacks, and so that they look more like tension type headache. Whereas females may have a higher risk of having increased headache frequency and more of lifelong duration of symptoms. And so why do we see these sex differences? I don't have time to go into a lot of details, but we do have, data from many different ways of looking at sex hormones to show basically that estrogen is pro-migraine, pro-nociceptive, and testosterone is protective. So a few examples, there was a study that was actually published just a few weeks ago that showed that cumulative exposure to estrogen over a lifetime is associated with migraine prevalent cases. So if you have a later onset of menarche, that is protective against migraine. And if you have had more babies or more years on an oral contraceptive pill, that increases the risk of having migraine. There's also data to show a case control study that's quite interesting that compared luteal drop in estrogen between women with migraine versus control women, and showed that women with migraine have a faster drop in luteal phase estrogen compared to control women. And there's also data looking at hormone levels in men with migraine to show that they have higher levels of estradiol and lower levels of testosterone compared to men without migraine. What about gender? And so there's some emerging evidence looking at migraine and gender diverse people. We need a lot more work in this space because I think it's an important population with a high burden of this disease. But there's emerging data in adults to show that we know that discrimination in a healthcare setting is very prevalent, and about a third of adults with migraine will experience some discrimination in the healthcare setting related to their gender identity. And when I say gender diverse, this is sometimes defined a bit differently, but this would encompass anybody who has a gender identity that is outside of the expected norm. So people who are transgender, people who are gender non-binary, and other categories as well. There's also recent evidence to show that in gender diverse people, experiencing discrimination is associated with a higher disability related to migraine as measured by MIDA scores. In youth, last year, we published a study looking at gender diversity and recurrent headaches in Canadian adolescents, and we had a weighted sample of over 2 million kids. And we found that gender diverse adolescents had a 3 times higher odds of having frequent recurrent headaches compared to their peers. But then we tried to control for things that we think may confound that, looking at bullying exposure and mental health. And once we adjusted for bullying exposure and mental health, the association between being gender diverse and having frequent recurrent headaches wasn't there anymore, suggesting that it may not be the fact that you're gender diverse that you get more headaches, it's the psychosocial environment that you're exposed to that may increase the risk. And so what about geography? This is a figure from the latest systematic review looking at pediatric headache epidemiology, and it shows you where the research has been done on estimating the prevalence of migraine, tension type headache, and sometimes other headaches, but most of the work has been for those 2 diseases. So you can see that there's quite a few studies that have come out of the US, and then after, some areas of the Middle East and Europe. But really after that, the areas in yellow or gray have, 1 to 2 studies, or in the case of the gray areas, no studies that made it into the systematic review. I know they didn't cover all of the studies, like they missed one of our Canadian studies, but it does give you a sense of where we have better data and how bad our data is. We still need more work to estimate the burden of disease and prevalence of disorders in youth, I think. One interesting thing comparing different geographic areas was that they did find a hint, and this is based on not a lot of studies, as you can see, that there may be higher prevalence of migraine in youth, looking at estimates from the Middle East and Europe compared to the US and Far East. So there may be a higher higher prevalence of disease there for migraine. So what about the impact of race and ethnicity? So unfortunately, there's data to show that there are significant disparities in access to care and quality of care for Black youth or sort of Black people versus white people. So there's data in adults to show that Black people and men are less likely to access a diagnosis of migraine, and that white youth are more likely to get appropriate prescription for acute medications compared to youth from other ethnic groups. We also know there's an impact on socioeconomic status and access to care, unfortunately. So those with higher socioeconomic status in the adult literature are more likely to get consultation around their headache and a diagnosis of migraine. There's a higher prevalence of appropriate triptan use in high SES people in the adult population. And in the pediatric population, youth who are higher SES are more likely to be hospitalized for migraine. So we have problems with how we're delivering care, and there are big equity issues. So in summary, Migraine is the primary neurological cause of disability in childhood and beyond up until age 60. We know that there are established sex and age differences that are very interesting in understanding, I think, that help us understand why the disease happens. There's hormonal impacts and there's developmental brain differences that play into the expression of the disease. And we need a lot more research. So hopefully all of you will get motivated to do more research to help us understand geographic differences and then how social determinants of health can impact the disease and access to care. Because if we don't know, then we can't make things better. And that's all I have to say. Thank you.
Thank you very much, Serena. I always learn something from you, even though I know you were my fellow at one point. So I really appreciate those great talks that you give. Again, just as a reminder, everybody, put your questions and answers in the Q&A. Try to avoid using the chat. That'll help us organize things at the end. Next up, though, is Lucia Grazi, and she's going to talk to us about the evaluation of the patients. So
Thank you.
Take it away.
Hope you can see the slides. Thank you so much for this opportunity. My name is Licia Grazzi. I am the director of the Headache Center at the Vesta Institute, Neurological Institute in Milan, Italy. I will speak with you about a topic that seems very easy, that concern the evaluations of patients' clinical history of young patients with migraine. As we listened to a few minutes ago, migraine is an important issue with an important epidemiological relevance. Is associated with low quality of life, low social and school performances for the guys, with high disability, and also it's very difficult to treat. Moreover, we have to consider when we treat young patients that we have to face the patient, but also the family. And Lewis, many years ago, reminded that children, usually, what do they want? They want to be reassured that they do not have a life-threatening illness. They want to find something that will make the headaches go better very quickly. And also, what do the parents want? The parents want to know that the children do not have a brain tumor, for example. They want to find a safe and effective treatment. And generally, they want to learn more about the cause and the history of the headache of the children. So Rotner, many years ago, confirmed that the evaluation of the child or adolescent with headache is the key to appropriate treatment. And probably he was right, because history is important. It's important to get the headache characteristics. It's important the physical examination. And also, as we will see in a few minutes by my colleague Massimiliano Valeriani, it's important to define which kind of lab test we need. But there are some aspects that sometimes we over-evaluate and sometimes are mistakes. For example, we insist on the family predisposition. Yes, it's a risk factor, but sometimes, you know, my grandma got headache, my mother got headache, and so I am suffering from headache. It's not always sure. There are problems about the infections of sinus, and sometimes it is an aspect over-evaluate, or it's evaluated in a wrong way. There are problems concerning food allergies, and you know that there are so many young patients that do not eat anything because they are, you know, allergic for many foods, and they are not, you know, interested by the migraine phenomenon. And also cervical pain. So often we have to explain that cervical pain due to cervical problems is not so important at that age. But always there are, at the same time, aspects that we do not consider. For example, life events. The grandma died, the grandfather died, and these are important events for the life of young people. Trauma, family problems, the parents that divorce, for example, social problems with friends and other relationships that are important at that age. And also there are the school issues, and at that age they are so relevant, and we cannot do we have to consider them when we collect the history of our patients. In the last year, many reports confirmed that pharmacological treatments for migraine in young age are not always very helpful. We have the CHAMP study that confirmed that placebo was much more helpful than topiramate in that study. And also Locker in that review few years ago confirmed that pharmacological options are not always very effective. And in an interview, Powers and his collaborators, they considered the power of the placebo that can be very helpful in case of young patients. And these are factors that we have to consider when we meet young patients with migraine. Also, recently, migraine started to be considered a very complex phenomenon where there are biological aspects, but also social and psychological factors that are very strictly connected. And we have to consider all of them when we consider and when we meet young patients. And this new perspective is the present. So according with this kind of model, biopsychosocial model, and considering that the pharmacological options are not always very helpful, we have to consider a multidimensional approach for these young patients. And this approach have to be encouraged. So we have to arrange the sleep hygiene, the aerobic exercise. We have to identify migraine triggers when they are present, the diet, and to evaluate the life events that can be significant to induce or to worsen a migraine condition. Also, the education and the information, not only of patients, but all the family is very important in order to promoting long-term resilience, to enhancing the adherence to treatment, to empowering the caregivers as alliance, to addressing psychosocial factors, and to evaluating disability and avoiding behavior that are so appealing and so frustrating, in particular for young people. The successful management starts with a good history and different factors collection at the beginning. So it goes through the reassurance of patients and parents, to educate patients and families about the pathogenesis and the natural history of migraine, to establish realistic goals for every patient that we meet, and to be careful to the effects of headaches and the accompanying psychological distress. So to conclude, we can say that compliance and therapy effectiveness, any therapy, partly depend on patients' knowledge, beliefs, and perceptions. And so we have to build a positive alliance with patients and their families. The active involvement of patients and their families is needed from the beginning to reduce the risk of treatment failure. And multimodal programs have to be encouraged to educate patients, to learn pain coping strategies. And these programs probably can help to change the course of the disease and also to cultivate a good brain health status. As this personal view confirms, we do not have any kind of emotional safety without safety, and no safety without emotional safety. So thank you very much for your attention.
Thank you, Lucia. That was great. And one of the takeaways I think we can say, as I started out the beginning, is that we want to bring the headache care and management worldwide. And you highlighted exactly how much the provider and the discussion and the history can be done without any of the fancy equipment that's needed, and that really can make a large impact. So great, and thank you for that discussion.
Thank you.
Next, I'm turn to Max Valeriani, and he's going to talk about adding some of the laboratory and evaluation tests that may be indicated in need as we go through headaches. So, and again, as a reminder, for questions and answers, please put them in the question and answer box. Thank you all.
Thank you, Andrew, and thanks to the Child and Adolescent Headache Committee of the International Headache Society for the invitation. I appreciate it a lot. So my duty today is to speak of the procedures which are generally required for a child with a headache. So here are my disclosures. These procedures are usually asked when we need to differentiate a primary headache from a secondary headache. From a clinical point of view, there are some clinical points commonly called as red flags, which can address the suspicion of a secondary headache. For instance, a recent onset of headache or recent modification of the headache pattern in terms of either frequency or severity of headache attacks. Of course, abnormalities of pediatric or neurological examination, including also the examination of the fundus oculi, and the age. The age younger than 4 is commonly considered as a red flag. So when we speak of red flags in pediatric age, we must be careful because, so for instance, let's take the recent onset of a headache. Of course, in a 45-year-old person, the first episode of headache is highly suspicious for a secondary headache. Different is the case of a 6-7 years old child with the first episode of headache, because we know that the primary headaches begin really at that age. So here you can see the procedure which are more commonly required by the GP, neurological consultation. Unfortunately, I must say that this is not an initial request, because usually we see children who were previously visited by odontostomatologists, posturologists, gnatologists, and so on. EEG, blood examination, ophthalmologic consultation, X-ray for nasal sinus, and neuroimaging. So I would try to examine deeply some of these requests. Let's begin with the EEG. At least in Italy, it's very common that a general practitioner asks EEG for a child with headache. But is it useful? So I must say that the answer is basically negative, because for several reasons. First, EEG can be fully normal even in a child with a brain tumor. Second, some abnormalities, I mean, both slow and epileptic abnormalities, can be found also in children with migraine who had never had any epileptic seizures. So, for instance, in this study on a large population of children with headache. None of them was epileptic. EEG was almost ever normal, but few patients showed epileptic abnormalities, especially those with migraine with aura. So there are some, I must say, very rare cases in which EEG can be useful. For instance, in case of an atypical aura, which can pose a problem of a differential diagnosis with an occipital epileptic seizure, or when a confusional state is associated to headache for a well-defined period. Of course, a confusional state lasting 1 hour or more can be difficult to be interpreted as an epileptic seizure. Different is the case of a 10 minutes confusional state. So finally, the message is not to ask EEG for a child with headache. X-ray for nasal sinus. So the diagnosis of sinusitis is primarily clinical. So we don't need instrumental examination for diagnosis of sinusitis. And we must consider one important point, because sometimes I see children without cough, without any symptoms of sinusitis, treated with antibiotics just because they have headache. To suspect an headache due to sinusitis, there must be a sinusitis, first of all. And another important point is the age, because we must consider that the frontal sinuses are not completely shaped till the age of 8, 9. Thus, it is anatomically impossible to have sinusitis before this age. And sometimes we can see children, 4, 5 years old children treated with antibiotics. Nutrition. This is a great chapter because unfortunately, I keep seeing some colleagues, not only general practitioners, providing some prescription list in which a series of food or drink are forbidden. So this is not correct, because we know that at any age, migraine attack can be triggered by a food or a drink. But if we provide this list, we prevent to identify a particular food which can trigger the migraine attack. And moreover, there are some myths. For instance, chocolate. Consider that all provocative studies which try to trigger migraine attacks using chocolate failed. Okay. Another important chapter, which has been already mentioned by Licia, is that of allergies. So first of all, I must say that there is no evidence that IgE-mediated mechanism can cause a headache. However, it's true that many studies showed, and this is an example, showed a comorbidity between allergy and headache in pediatric age. I must say that we need to be very careful when we investigate a comorbidity between two largely prevalent conditions such as allergies and headache. Because in these cases, comorbidity does not mean automatically causal relationship, causal rapport. So it's true that histamine can represent the link between headache and allergies. Indeed, you know that many drugs used for headache migraine prophylaxis, especially in children, let's say, for instance, flunarizine or chinarizine, have antihistaminergic properties. This is very interesting, but from a research point of view, I mean, to better understand the mechanism underlying migraine. But in my opinion, it has no consequence on a clinical ground. I mean, there is no reason to make a child with headache undergo allergic tests. The same for celiac disease. Many GPs ask for tests to diagnose celiac disease in children with headache. In this meta-analysis, you can see here that just one study showed a real comorbidity between celiac disease and headache in pediatric age. So we must be aware that migraine is a disease in which any condition of malaise can trigger the attacks. So of course, is not how can I say, it's not difficult to understand that in condition which can cause malaise, such as allergies, for instance, spring, or celiac disease, migraine attacks can become more frequently of course, in a patient with migraine. So, finally, we arrive at the case of a child in which I can recognize one or more red flags, and I need to ask for a neuroimaging examination. What to choose, CT scan or brain MRI? So the first response should be MRI, because MRI is a more sensitive examination as compared to CT scan. But there are, and mostly MRI does not have radiations. But there are some points to consider. It's true that MRI does not have radiation, but in children younger than 7, it often needs general anesthesia to be performed, while CT scan can be performed in children over 3 years without general anesthesia, usually. And moreover, it is really more sensitive. But what we need from neuroimaging? Generally, we have to exclude brain tumors, and this can be excluded also with CT scan. Thus, I think that especially in certain settings, emergency setting, for instance, so CT scan can be considered as a first choice neuroimaging examination. What about radiation? It's true that CT scan has radiation, but this is what the American Association of Radiologists tell us about it. So consider that the dose of radiation for a CT scan is in children is 2.8 millisievert, while the threshold over which there is a concern for cancer is 100 millisievert. And moreover, with 10 millisieverts, the risk for fatal cancer is 1 to 2,000, while the natural risk in the US population is 400 to 2,000. Thus, we don't need to be afraid to suggest a CT scan in a child. Lumbar puncture, this is usually not required by GPs, but I must say that there are some conditions in which it is mandatory. You know that in adults, lumbar puncture can be used to exclude a subarachnoid hemorrhage, but this condition is really exceptional in pediatric age. At this age, however, lumbar puncture is mandatory when we suspect an idiopathic intracranial hypertension. You can see here the criteria, the famous Friedman criteria for the diagnosis of IIH and the criteria of the International Headache Society for the diagnosis of headache associated to idiopathic intracranial hypertension. And both of them suggest consider the measurement of the opening CSF pressure as mandatory to reach a definitive diagnosis. I like to underline this point because unfortunately I keep seeing children treated with acetazolamide for IH who had never had a measurement of opening CSF pressure. Thus, so you can do this diagnosis just after having performed a lumbar puncture. I can go to the conclusion. So usually in pediatric patients with headache, an accurate pediatric and neurological examination, including, of course, the fundus oculis. Fundus oculis can be normal even if in presence of a brain tumor, especially if the tumor is located in the posterior cerebral fossa. This is true, but it's true that whether the fundus oculi is abnormal, so there is a papilledema, we are obliged to ask for further examination. And careful medical history can be sufficient with no need of further instrumental investigation. Of course, we must be particularly careful whether there are some red flags. If we need a neuroimaging, CT scan can represent the first choice examination. And of course, I have to conclude that probably the clinical experience in pediatric headache represents probably the most important tool we have. So I began to deal with pediatric headache around 25 years ago. And at the time, I asked for much more instrumental investigation than I do now. Thank you very much for your attention.
Thank you, Max. That was great. And again, goes along with that trend that we're discussing. That we can do this. We don't need a lot of stuff and equipment, but if you have it, you can look for it. So I'm going to open the floor to questions and answers. I'll sort of moderate these to the group and see what they think. So far, we have one question. So for those 112 people that are online, if you have questions, let us know. And thank you all for spending your time with us. This has been great. We didn't think we'd get nearly this many with the late announcement. While people are thinking of questions, and I'll start with the first one here in a second, I do want to let everybody know, if you do start to log off, that this is a series that we're planning, and the next grouping is going to be more of a discussion of the treatment. So we'll talk about acute, preventive, and behavioral treatment. The one following that is really more of the outcomes, behavioral approaches, and education and expectations of families. After that, if things continue to do well, we'll continue to expand on that. So we want to really go from the basics to the complex and hopefully meet everybody's needs. And if, as people find these are interesting, to continue to build on it. Again, as we said at the beginning, these are being recorded. So if you missed any part of it or want to go back and review things, they will be available and posted on the International Headache Society library of discussions and talks. So with that, the first question, and anybody can answer, although I suspect from the wording of it, it was directed a bit more towards Serena, is that considering the migraine as a syndrome or symptomatology that involves early childhood and adolescence, and early diagnosis relates to the outcomes. So that early diagnostic pattern that you talked about. And I can answer this too, but I'm going to turn it to you first. Do you think ICHD2 was better than ICHD3 in terms of sensitivity? So we can all take a shot at it, but Serena, I'm going to let you take the first shot.
Here, there might be some heated discussion. I guess my short answer is yes. I think this is a very common burdensome neurological disease. And I think that in younger kids, we have seen data from Dr. Hershey that the duration can be lower. And I think that anything that we can do to increase the sensitivity of the criteria, this is my bias, is a good thing. Because I suppose the harm is that then you make people falsely reassured that it's migraine when it may be a secondary headache. But generally, the shorter headaches are in the younger kids, and we tend to investigate them more anyways. So that's my take on that. I'd love to hear what the others think.
Max, Lucia, what do you guys think?
So I must confess, Andrew, and you know, because we spoke together about this point, that I was quite disappointed when I noticed that the shorter duration of a headache for the diagnosis of migraine was moved from 1 hour to 2 hours in the last version of the classification. Because, of course, in our experience, there are many children who have, especially young children, I mean 5, 6 years old children, who present with typically migraine attacks lasting 1 hour or even shorter than 1 hour. Thus, I think that in these cases, the last option, the classification provides us is to classify this headache as undefined. So I think that probably we need, of course, more evidence about it, about this point. But I think that this could be rediscussed in a further version of the criteria.
Lucia, you have an opinion on it? I'm sure probably you all do also. We all do. You're muted. I'll give my idea while you're unmuting yourself. But you know, my concept is, again, if we go back to the theory that we're diagnosing a disease, not an event, is that concerns of individual short headaches is less of a concern as long as we can classify enough headaches that are in that longer duration component. And if we define duration as not just the pain episode, but from normal to normal, and if sleeps can be included in there, which we're allowed, oftentimes over a year's period of time, parents are able to identify several long patients that would qualify. And it's really to sort out the difference and make sure. I worry about the really, really short headaches that could be classified that may be a post-ictal headache or a seizure-related headache, especially if they've got a presenting symptom. So I'm not opposed to the changing it from 1 to 2 hours. I think that does recognize and make it a little bit more criteria. That being said, again, the overall diagnosis is migraine. So we're focused on migraine without aura. There's also probable migraine in the category. So if things are close and they're missing one criteria, such as the duration, you can still make the diagnosis that it's probable migraine and follow these kids as they get older and doing it. So I think there's ways around it. I know behind closed doors when we were discussing it, there was a lot of discussion about the 1 and 2 hours. And the problem is there's just not a lot of great evidence for the 1 to 2 hour exclusively. So kids that never have a headache longer than 2 hours, because that's the point, is that if you have headaches longer than 2 hours, even if you have short headaches, you can still be classified. The other reason is that, and this is something that we can probably discuss at the next seminar in terms of designing studies, especially the acute treatment studies, is when headaches respond too quickly, then the studies can't be looked at in those kids. So really looking at kids that have a headache long enough that medications can be studied for their outcome. So I'm going to take that idea that I'm okay with the 2 hour. To get back to the difference, and that's the only difference really that we have is this change from ICHD2 to ICDH3 is the duration. Everything else is about the same. And so if we do some give and take and say we really want to diagnose a disease across the ages, and this was something that Jess Olson, when he presented it to us as a third edition, is the theory is that let's try not to make too many carve-outs so that we really can approach it. Richie, I don't know if you have anything to add. You're still on mute if you want to add anything. Okay. So moving on to the next question. It's actually directed just to you, Serena. But the question is, and if you can see it, is in there too, and everyone can hopefully see it, is that they're from Turkish, and they're curious about why they may be more prone to migraine. So I think this relates to the map of the world that you showed, and the country of Turkey seemed to have a much higher incidence than other areas.
Yeah, so the map was actually looking at the number of studies that were done to estimate the prevalence of pediatric headache disorder. So it wasn't specifically commenting on the differences in prevalence. It was just like, where do we have studies to estimate the epidemiology? And, you know, there's some very good pediatric headache people in Turkey. And I think that's why there's been more studies out of there. In that particular systematic review, they didn't report country specific from what I recall. So I don't remember, honestly, if Turkey had a higher prevalence. I could look back and type it in a minute. But in terms of what they did show is that overall in Europe and the Middle East, there was perhaps a higher prevalence of migraine compared to the US and to the Far East. And I don't know why that may be. So a few ideas is one, perhaps there's more resources there to make a diagnosis. So that could be one possibility, although there's quite a few resources in the US, or more knowledge about migraine in that part of the world. It could also be because migraine is highly genetic. So the heritability of migraine is between 40 to 70%. And there could be those two areas, Europe and the Middle East, are clustered geographically together. So is there something about the genetics of that part of the world where there's a higher burden of genes associated with migraine? And I think in terms of, and Andrew, I'd like to hear your thoughts about this too, but what we understand about migraine genes and susceptibility genes is mostly based on data out of like the UK and European populations, and we don't have as much data on different populations. So I think we don't have a good grasp on the different geographic distributions of migraine susceptibility genes. But Andrew, I don't know what you think about.
I mean, you're exactly right about that. I mean, there's been some fairly great large studies that are based out of both the Broad Institute in Boston and the Netherlands at Leiden. But the problem is that if you look at the control for looking at migraine variants, that it tends to be a very focused sort of white Northern European group that's being looked at. So that does bias those genetic studies. Unfortunately, it's a give and a take. It's the broader you make the study, then the more polymorphisms that may or may not be related to it can show up. One of the concern I think about it is stigma, and that in some places in the world there's a stigma against either admitting you have headaches or making the diagnosis of headaches. And perhaps in some of these areas where we see a higher epidemiology is not due to actually a disease difference, but just people are more willing, and when they fill out the epidemiology surveys, to admit the features and say it's not it is a disease I have. It's not because I'm making a mistake. I'm doing something wrong. So that could be part of that component issue. So I don't know if anybody else has any other ideas, or people in the audience have other ideas. Put those in the chat box for the questions. I'm going to ask one. There's one more question in the question, but then there's lots of discussion in the chat. So I'm going to do the next question, and then we can jump to the chat a little bit. And if we run out, we run out. So the next one is discussing a little bit of managing and treatment. And comes from Dr. Bostros. One thing is the next seminar is going to talk more focused on management and treatment, so I don't want to get too deep into that. But the specific question was about physical therapy for pediatric migraine management and headache treatment. So that cervicogenic component, I think it relates potentially to more what Gia and Max you talked about is that's both that diagnosis and evaluation that leads to it. So I'll let one of you two take that on.
So I must say that I don't think that cervicogenic headache exists in pediatric age. But of course, this doesn't mean that physical therapy must not have any place for treatment, because it's true that especially in chronic conditions, when there is a chronic pain, this can lead to a sort of a contraction of the muscle in the neck and in the head, and this can cause a vicious circle because of course muscle contraction can increase pain. I think that in this case a physical therapy can be useful, and I must say that send some difficult patients with chronic migraine to have also physical therapy. I must say, and I must underline that there is no clear evidence in randomized control trials that physical therapy in children with migraine can be effective.
I mean, I agree. I think there was a great study in adults done in Denmark, where they actually had people wear needles stuck in the muscles of their neck to try to identify a cause and effect. And then I think Jess Olson started it.
If I say a comment about this, I absolutely agree with Massimiliano about the cervicogenic headache that is not so common in children, and maybe that we can enforce a physical therapy for difficult patients, but at first we have to encourage young patients to do physical exercise, because the most part of the young patient, they do not do anything about that. And so I think that that is the first step. You are right, there are no studies that can demonstrate the utility, the efficacy of this kind of approach. But once again, if we consider our patient in a multidimensional perspective, physical exercise and also in some case physical therapy can be helpful. We are not here to say that pharmacological treatment are not effective. They are very helpful, and probably in the next future we will have pharmacological options very helpful and very safe. But it's possible that to face these young patients, we need to use a multidisciplinary approach.
I agree with that.
I'd like to
But it was
comment.
Go ahead, Serena.
Yeah, so in terms of physical therapy, so I agree. And we recently looked at the literature, like we couldn't find anything that was high level evidence for physiotherapy and migraine. So just to reinforce what everyone's already said, I'd say there's, I think, two clinical scenarios where I find it beneficial. One that I would say has some level of evidence from a small RCT. So that first scenario is the patient who's had chronic post-traumatic headache, who still has features of vestibular oculomotor dysfunction on exam. So in a patient who has had a concussion as sort of a sentinel event that started off a higher headache frequency or started off the headaches, I will assess them for vestibular oculomotor function. So we check saccades and smooth pursuit. We look for nystagmus. We check the near point of accommodation, or sorry, near point of convergence. So you basically kind of say, you put your finger in front of them and have them try to converge, and then ask them when they start to see kind of blurred or double of your finger. And in a child, it should be 6 centimeters or less from the nose when they start to see double or blurred. So if it's farther than that they're starting to have that post-concussion, that would be an indicator of oculomotor dysfunction. And then we look for symptom exacerbation with the eye movements and moving the head. And then for ongoing vestibular dysfunction, there's different ways to do it, but often I'll just have them stand in tandem with eyes open, then closed, and then on one foot. And if they're really having trouble still balancing themselves after the concussion, it may be an indication of ongoing vestibular. And there's some data from a small trial that was actually done out of where I'm in Calgary in adolescents and young adults that showed that vestibular and oculomotor rehab with a physiotherapist in the setting of post-traumatic headache can be beneficial to return to play and possibly other outcomes we don't know. So the chronic post-traumatic headache that still has some stuff with their eyes and their balance, I think, can really benefit, and I've seen that clinically as well. And then the other population where I would say I use it more is the kids who have a very chronic daily headache or continuous headache picture, where they haven't gone to school in forever and they've been lying in bed for a really long time and they don't even know how to do anything physical with their body anymore. And I'll send those kids to a physiotherapist to work on physical reconditioning. But yeah, that's, I'd say, when I would use it most.
Yeah. I mean, that's great. Yeah, both for the evaluation and management. What I was going to finish up was what Jess Olsen and Masada Sheena did in Denmark, was have adults wear needles stuck in all the muscles of the neck to see a cause and effect. Is what was causing it? Was the neck muscle causing the headache, or the headaches causing the neck muscle? And at least in my interpretation of their studies, it was pretty clear that the headaches, especially as the frequency went up, triggered off the tightening of the head of the muscles, and that once the headaches got under control, the muscles were not. And it's an interesting study. Quite a good volunteers to wear needles stuck in the muscles of their neck for 2 weeks while they assess the time period. So I don't have the paper right in front of me, but Masada Sheena and Jess Olsen, I know, worked on that. There are 2 questions in the question and answer that are open. Both relate to use of prophylactic medication. Since that's our next topic of our webinar, I'm going to defer those questions and encourage the people that want answers to that to come back, because that's a whole discussion all by itself. The only caveat I'd said is there are medications used mostly off-label for this age group, but one of the things that we've been able to show that relates to outcome is that once you get the headaches under control, they can go off the medication. So it's not a lifelong treatment, it's to really get things under control. But the things that Licia and Max talked about, that it's really, as well as Serena, and is that it's really the outcomes to improve it require more than just medications. And that's that healthy lifestyle habits, the exercise, taking good care of yourself, and evaluating that or recognizing that in the early stages of evaluation and improving the healthy habits can go a long way in making it better. And was probably the major reason why our CHAMP study was actually viewed as by some as a failure. We view it as a success of everything, because 70-80% of the kids got better, but even the placebo arm, but everyone was instructed that they had to take good care of themselves to be in the study, and that probably has a major influence. So I'm going to skip those two questions. The last question I have in the question box, and we'll jump to the chat, is that is migraine with aura can become migraine without aura in children and adults? So I'm guessing the direct question is are these two separate things, migraine without aura and migraine with aura, or how they evolve and change over the developing childhood? So I'm taking that later changing and inventing the question is the presentation of aura and without aura. So somebody want to take that on, is how does oral presentation evaluation approached for children and adolescents?
Yeah, I think that's hard, because I think we don't, to my knowledge, and please others correct me if I'm wrong, we don't have any studies that I'm aware of that longitudinally followed the same children to see how their aura changed or didn't change or evolved over time. And so I think it's hard to answer from a data perspective. In my talk, I showed that we know that aura is more prevalent in the older sort of adolescent age versus the younger kids, but it's hard to know whether that's because we have trouble assessing it at a younger age because they don't have the verbal skills to explain very complicated symptoms, because most of the cases are visual aura and they can be very weird. One thing I would say from my experience, and I think Dr. Hershey will agree because he trained me, is that the visual aura in younger kids can look different from what we typically see in older adolescents and adults. So, in older people, the most common type of visual aura is a fortification spectrum, where you see like these jagged colored lines and then kind of like a scotoma, like grayed out, blurred out in the middle of the colored lines, and it can gradually increase in size. In younger kids, it's not as common to get that like beautiful description, but we often see them saying that they see like little black dots or dots of some color as being more common in the younger age group. The other comment I'll make, just from my clinical experience, not from the literature, is that when the headaches start more episodic and have a migraine with aura component and then become more chronic, like chronic daily headache or continuous, they often, in my experience only, will lose the aura and just have kind of the chronic pain and have less aura when the disease becomes more chronified. And I'm not sure if that's because their brain is in this like chronic state versus, having the ability to have episodic cortical spreading depression, which is the underlying phenomenon for aura. But I'd love to hear what others think, because I think we don't have a lot of data to answer that question well.
Yes, if I can have a comment about this. So I agree with Serena that usually when there is a chronification, the episode with aura tends to drop. But so in many patients there is a coexistence of migraine with aura and without aura. And in patients starting with migraine with aura, sooner or later some episodes of migraine without aura will appear. So instead of probably an interesting question, which is not in the Q&A, is that, and the answer is yes, is that a tension type headache can transform into migraine in pediatric age. It is true, and it is true also vice versa. I mean, there are patients with migraine, which at a certain point develop more tension type headache characteristics. And this is interesting because it supports the idea that tension type headache and migraine, at least in pediatric age, can represent one only disease. With two opposite poles of severity, migraine more severe and TTH less severe.
Any comments?
I agree. That's true. It's so difficult because you can see one patient in February and you are sure that every symptom is, migraine without aura. And you can see the same patient 3 months later and everything changed. So it's not so uncommon in young patients. And sometimes this can make it difficult, for example, to enroll patients for the studies because you see the patients, you have an idea, and 1 month later you have another idea, and everything changed. But at this age, everything changes so quickly that we have to consider this kind of aspect. So I agree completely.
So we did address that concern in ICD-HD if you read some of the commentary and discussion. And one of the things that in ICD-10 1 and 2 that people focused on was trying to make a single disease diagnosis and only limit a person to one thing. What we tried to say in 3 is that people can have multiple things. So, people can have migraine without aura as well as migraine with aura. And if it's frequent, also have chronic migraine. And if you've girls that start having menstrual period, have menstrual-related migraine. And if you hit your head playing soccer, you can get a post-traumatic headache that has migraine features. So you can include all of them, and it really gives you a full picture of the patient. We don't have to try to say, well, we can only call you migraine with aura because your other headaches don't count, only the ones you have the aura was. The one thing that we did discuss is that with the recognition that tends to be that headaches due to migraine have a larger impact, generate more disability, and have a bigger lifelong need, that migraine trumps tension type headache. Meaning that if they have both, you want to focus on the migraine. And there's some evidence from adults, the continuum model and the spectrum model. Continuum was Roger Cady, spectrum was Richard Lipton, but the same concept. Is it one disease that tension is just the very minimal part of the disease, or it's separate? From Richard's study, it seems that people with migraine can have the full spectrum, meaning they have very mild headaches that resemble a tension type headache, but still the disease they have, if you ask for a year's worth of headache history, fall in the migraine category. Well, there seems to be a subpopulation of people, and we don't really know the size, as Serena said, because it's not focused in the epidemiology studies well, that only have tension type headaches. They never have a headache that has any feature suggestive of migraine. And so it really suggests there probably are 2 separate diseases, but once you diagnose migraine, it's migraine. Now, for the presence of aura, I think there is a biological component because we clearly see the younger kids, even with the difficulty explaining it, there's just fewer kids that describe an aura. And that oftentimes if you see a very young kid describing an aura, especially if it's very brief, like less than 5 minutes, you really have to be careful. Is it really a seizure with a postictal headache? Whereas we typically, and this is anecdotal, but usually don't typically start to see the presence of auras until the late teens, early 20s. And since some of the genetics have actually identified that having aura in the family makes you 4 times more likely to inherit it, it probably has a much stronger inheritance pattern that may be represented by genetic expression, with some suggestion that it's an estrogen modeling system, that the estrogen sensitivity may trigger it off. I'm not sure I buy the estrogen sensitivity, but I do buy the concept of the development later. And so I oftentimes ask when I'm evaluating a child that, or an adolescent more typically, that they're starting to come into us because they've developed a new symptom, and that new symptom is aura, to describe the aura. But then I ask the parent, when did you start having your auras? And it oftentimes is the late teens, early 20s, or many say, well, I had my first aura when I was in college, I did an all-nighter, and I woke up the next day and had this symptom. And since then, I occasionally get these auras. So I think auras probably do develop later than our other symptoms, and I don't think we have a clear biological answer to why that happens. That being said, we do have young kids that describe it. The younger kids, I do say a lot of them, especially if they have co-associated lightheadedness, it's hard to teaser out phosphors. So when you have diminished blood flow to the back of the eye, to the retina, it'll have spontaneous discharges. And so you have a retina-generated phosphors. Those are not auras. That's just the lightheadedness. So it's getting it, as Serena, you said, that getting the history of what it actually looks like is important. So one of the tricks I often do, this is more of a pearl, is you can induce the same effect of lightheadedness phosphors by not gently, but fairly intensely rubbing your eyes. And when you rub your eyes, you're actually pushing the blood out of the retina, and then it'll cause that spontaneous discharge. So when the kid that I have questions that is this an aura or not, I'll tell them, rub your eyes really hard. Is that what you see? And if they say yes, it's like, well, it's probably your lightheadedness and not the typical aura type, which should really be CNS based. So we have another question. As I said, I'd run out of the question box first and then go to the chat. The one in the chat, unfortunately, Vincenzo asked, and then he had to leave. But I think it's directed to you, Max, is what's your opinion on the past recommendation that if somebody has an exclusively occipital headache, they required imaging, and now the newer evidence that says that's probably not the case? What's your opinion on that?
So difficult. So my opinion is that it's very difficult to define a rule for neuroimaging. I think that of course guidelines are necessary, and we appreciated for instance the diagnostic guidelines we had in the past. But I think that, so the last point of my presentation I underlined, it is to be considered because I think that the personal experience, the amount of personal experience with children with headache is that which can help more in this situation. So I must say that now very rarely I ask for neuroimaging in a patient, even after the first episode of headache. But of course, I don't tell the young doctors coming to work with me, for instance, not to do it, because rules are necessary, guidelines are necessary, but I think that they must be always filtered with a personal experience.
I agree. And I think that our clinical personal experience is important in this for this point. And of course, in my case, I'm working in a third level headache center. So the most part of young patients that arrive to my observation already have an imaging examination already done, because in many cases, the pediatrician or the GP suggest to arrive to our observation with an imaging already done. On the other hand, if I have to be sincere, I collected some not very nice experience in my practice. I'm getting older, so I can see that. And so in the last years, when I consider some difficult patients or patients with a new onset of migraine or some atypical signs, in those cases, I suggest an imaging for those patients. This is our experience here.
Yeah, if I can comment, I agree. We have to keep in mind where we all practice. I'm also in tertiary care. I would say a lot of my new consults have not been imaged, but people have thought about other things first, and that's why they've ended up with me. And I'd suspect we're all similar, so we need to hedge what we say. I think there's now the Gelfand study that I put in the chat and one or two others that have shown that, occipital location may not be as hard of a red flag as we used to think. I think it's all contextual. In a younger child with limited verbal skills, where we're more worried about like our ability to examine the child and to get a good history, we still need to think of posterior fossa tumors, which is the main reason for that red flag. But I think older, good history, confident in your exam, confident in your fundoscopy, no other red flags. I think it's an orange flag, in my opinion, where if you're still nervous, your spidey sense is going off, you could image based on that. But if everything else is very reassuring and you're confident in the whole assessment, then it's reasonable not to image if the only thing is occipital location.
Yeah, and I agree. I think that oftentimes the exclusive occipital is hard to get when you start saying, is this hurt anyplace else? And the kids will respond yes. But I think younger age, it's almost a necessity because you can't get a full history. What at that young age is defined. Currently, the guidelines are 6 and under, but realistically, you probably a 5 and 4-year-old can give a fairly good description most of the time. I can say in that, I can tell you the number one reason we probably do imaging is parental anxiety. So oftentimes that can be reassuring with the families and say, we can always order this if things aren't getting better, but the bad things you worry about, the tumor, the growing blood vessel malformation, are going to get worse, not better. So if the child's getting better, then it's unlikely to have that. And that oftentimes can help reassure the patients when there's no indication, or the parents. Patients, the kids usually don't care that much. It's the parents that are worried. I have one last question, and I think we covered everything in the chat. One last question in the question and answer, and it's touched base to some of the discussion we've had of diet, exercise, and vitamin replacement, and what is your opinion on the reduction of frequency and severity in terms of that. So, Lucia, I think you brought that up first, so I'll let you answer that first.
Thanks. I think that, as we already said, it's important to observe this kind of habits. And skipping meals is so common, and so we have to educate patients to avoid the skipping meals. The absence of physical exercise. Physical exercise is important for pain. And so all these kind of procedures can be helpful for improving and also for improving the efficacy of medication. I think that there is no one or the other one, the most effective, and they are all very helpful. There are no, at the moment, studies well conducted, that confirm that these kind of procedures are effective. But the clinical practice suggests that they can be helpful for patients, and also that they can be included in a program, in a strategy for helping patients with migraine, in particular for difficult patients, where this kind of things are not very well considered. So the suggestion is, if we can, to consider all these aspects and to include them in a program for helping patients. This is our opinion here.
Yeah, so I agree. I think like Dr. Grazzi said, it's the level of evidence for the for most of what we do, but for the lifestyle piece is low, and it's based on sort of observational data to show that, youth with frequent headaches or migraine are more likely to do this or not do this or that. But we don't have like RCTs, which, I think it's because they would be very hard to do. But there's interesting data. I was just preparing for a post-traumatic headache talk, and there may be data in the migraine literature like this that I'm not aware of, but there was a really nice study in veterans who had post-traumatic headaches that did a cognitive behavioral therapy intervention, and they randomized them to that or kind of routine care, and they measured self-management efficacy, like treatment self-efficacy, which means how much the patient feels confident that they have skills in their tool set that can help them manage their headaches. And they found that was strongly correlated with headache-related disability in the post-traumatic patients. So I think that is like just a very nice nugget of knowledge. And the way I interpret that and the way I think we can harness that for therapy is kind of a shared decision-making model where you identify some lifestyle habit, one or two, that the patient is engaged with working on and willing. They're kind of at a stage of readiness in the stages of readiness for change where they will engage with you to work on. And even if it's just one thing initially, to get some buy-in that this is something that you control about your treatment plan, to give them that sense of control over their pain trajectory and their treatment. I think that's really psychologically powerful. And it may not even matter which component it is to begin with, but it's that benefit of feeling like they're taking some ownership over this, especially when we have really overprotective parents, which we know from the pediatric chronic pain literature is associated with poorer outcomes. That can really kind of enable the child or adolescent to take some ownership, and that can help them.
Max, Amy.
So I think that the CHAMP study showed that placebo has an efficacy of more than 60% in children. And it is a challenge to find anything better than 60% among drugs. Apart from this, I think that surely regular lifestyle concerning food, concerning physical exercise is very important in treatment of pediatric migraine. So one thing I often tell the parents of my patients is that a routinary life guarantees a good outcome of migraine. So the question is, and I want to be provocative, how fun is a too routinary life?
That's true. That's true. Absolutely. And when you meet patients about 18, they are so scared. Oh my God, I have this life.
Yes, sorry,
That's
Lisa. I remember a 17-year-old patient, and he told me it's not possible that every Sunday morning I have this terrible headache. What do you do on Saturday? I go to discotheque. Okay, so stop to go. Oh, I prefer to keep migraine.
That's true. In fact, it's important that we explain very clearly that the life can go ahead and that they do not have to avoid to do something good for them, because the avoiding behaviors is terrible, and increase the sense of disease and so on. But we have to teach them that they can be aware that there are some particular specific circumstances that can make migraine worse. And it's not a problem. You know that, and you can manage that. And
Yes.
So you can live with migraine and to go to the disco till 3 o'clock in the morning, okay?
Exactly.
I'll analogy that a mentor of mine who's an epileptologist talked about for epilepsy patients and described it that it's like a bucket, and we all have a bucket that's our brain. And most people, the bucket's about half full, but if you fill it up all the way, it can spill over. And so I use a similar analogy with headache kids. And I said, the purpose of the healthy habits is to lower that water level. But you can do things to yourself to raise it, like staying up late going to a discotheque, and you're going to pay the price. So with that understanding and that balance in life, and said, the reason is that you just all of a sudden didn't develop something new. It's that you're paying the price for what you're doing, and telling a teenager, and I know Serena has heard me tell patients this is that I will ask the kid, I said, well, whose headaches are they? And the kids will say, they're mine. I said, well, then who's responsible for taking good care of yourself?
Yeah.
It's not your mom, it's not your dad, it's you. And if you don't take good care of yourself, you're going to pay the price, because that bucket's going to overflow and you'll have a headache. And I think that sense of ownership, to as Serena said, that it's really you're the responsible party, helps a lot of kids. Sometimes kids need a parentectomy, which means they graduate and go to college to learn that. But I think that's a useful analogy.
Yeah.
We don't have any more questions. I don't know if the panels, if you have any more comments. I do want to thank all of you. I think this has been a great discussion. In fact, the presentations were great, but I would say the discussion was even greater. And so for people that have remained online, we've lost about half the audience. So I know people have a busy life and clinics, and for those people where this is late at night, probably have to go to bed, and those people that are just waking up are still getting their first cup of coffee. So I would say thank you for the audience. Thank you, all four of you, or all three of you, with Henrik in there too, for his background, technical management and recording of this. I think it's great. Look forward to the next one. Hopefully it'll be, we're anticipating doing it every 3 months. So looking at potentially sometime in May. Try to avoid other meetings and conflicts so that as many people can get on it. But great way to bring this information to people that normally can't go to meetings or in different parts of the world. So thank you, everybody. Lucia, Serena, Max, any other comments?
Thank you.
Thank you for the invitation. Thank you to all of you.
Yeah.
Thank you, and have a good day, whatever the time you are.
Yeah.
Thank you. It was a real pleasure to be invited, and the discussion was very fun. Thank you.
Bye-bye.